Good afternoon, everybody. If we could start to take our seats, I know it's a little hard after lunch, but we'll get started. So we're going to start this afternoon off with a session on gynecologic indications, and then soon after that, we're going to have a bunch of really innovative talks on technology breakthroughs and technology gaps, and then have a few special lectures from special people, and also look at reimbursement issues. So it's an afternoon with a lot of important information for us. Everyone's coming in. So for the gynecology panel, I'm particularly excited about this panel. It's close to my heart. Here in the United States, uterine fibroids was the first FDA-approved indication in 2004. So we have a lot of experience, but we also have a long way to go to improve the treatments and improve the care of millions of women that are suffering from this disease and other gynecologic disorders. So I'd like to formally introduce Dr. Martin Boomsma to be the moderator of this session, and he's prepared a lot of interesting questions for us all to ponder and hopefully improve the field. So Martin, the floor is yours. And I also want to remind everyone that in the app there are numerous pre-recorded presentations that involve gynecologic indications, and I hope you all go there and listen to those amazing presentations. So Martin, here you go.
Good afternoon. Thank you, Suzanne, for the invitation. Hello, everybody. I hope the lunch was good. Was it good? I think it's amazing, right? So, my name is Martin Boomsma. I'm a radiologist from the Netherlands. I work in Zwolle, Isala Hospital, and work closely together with the University Center of Utrecht. It's a pleasure to be here to tell you a little bit about our experiences in treating patients with fibroids. But I first have some questions for you. While you got to know me, I'd like to get to know all of you. Some of you have familiar faces, but how many people are actually here treating patients with HIFU? Okay. How many get paid? Okay. Are your treatments in the guidelines? All right, let's get started. So I wouldn't be here without our team. It's always the obligatory picture, but it's only through the amazing efforts of the whole team. They come in when they have a day off, etc. So all the things you see here, 7 years of research in 5 minutes, it's mostly because of their efforts. Okay, so Suzanne asked me, Martin, can you give an overview of what has been done? What's the current knowledge? Which lacunes are out there in this field? And we started off 7 years ago by studying the literature about, okay, how effective actually is a treatment of a fibroid by HIFU? Because we had a period of restrictive protocols. We didn't ablate all of the fibroids. But now we did a new systematic research about unlimited ablation. So we went through the literature, and the most important summary is here, that the reintervention rate after HIFU is between 0 and 21% after 3 to 34 months, and the symptom severity score decreased by 60% over 12 months, and the quality of life improved by 30% in 6 months. We had the availability of a data set from the University Medical Center in Utrecht. They started off, as everybody, with restricted protocols. So we could compare the restrictive cohort with the later unrestricted cohort. So this was another step forward in identifying the effectiveness of treating fibroids by means of MR-HIFU. We saw a reintervention rate of 18% at 40 months, and no other events occurred after 4 months. We see often referrals of women who wish to conceive, and all other causes of infertility are excluded. And we thought, again, as a good starting point, okay, what's the literature out there? What's actually known about the reproductive outcome after high-intensity focused ultrasound? And this was a difficult one, because there are no prospective trials, no prospective cohort trials, or let alone randomized clinical trials that actually give confident evidence in this field. A lot of anecdotal messages here, but anyway, pregnancy percentage between 7 and 36%, miscarriage rate between 8 and 50%, and time to pregnancy between 0 and 36 months. So there have been quite a few HIFU babies, and we have had some of those as well. Okay, that's a good starting point. Then we needed to overcome some challenges because treating patients with fibroids comes with problems. Eligibility for screening, for example, but also the treatment itself. And we developed and clinically evaluated a 3-step modified manipulation protocol. What does manipulation mean? You can manipulate the uterus. You can manipulate it by filling and emptying the bladder, or filling and emptying the rectum, and even manually try to maneuver the uterus in the right position in order to have a good focus point and to treat the fibroid. These treatment improvements have improved eligibility amazingly, and also increased the effectiveness of the treatment measured by non-perfused volume. And we discovered that you need a non-perfused volume of 63% to be effective. But we're not there. The Funaki classification is used to estimate whether or not your treatment can be effective. But this is, people who treat fibroids know that there are some Funaki 2 patients that cannot be treated, and some Funaki 3 patients can actually be treated. So we are desperately in need of a better predictive model about which patients are suitable for treatment. And the treatments need to be quicker, faster. And one of the points we addressed is the use of medication, carbetazine, before treatment of fibroids by HIFU. And it's a medication you can use to dry out the myoma and have a quicker lethal thermal dose. And finally, we do not have a tool to see actually what we are doing. We can see where we are doing something, but we cannot actually see what we're doing because we cannot evaluate the treatment during the treatment. We always evaluate our efforts after the treatment. And although we all know that when you put cells in a certain area of the myoma and you see differences in the upslope of the thermal lethal dose, that you often think, I think there has already been done something here in the near field. What we did, we used a wide range of diffusion-weighted imaging protocols, and because we had paired data with a non-perfused volume assessed by gadolinium infusion, we were able, by using deep learning algorithms, to actually obtain images that, as you see here, are quite similar and readable for the average radiologist. And this has just been accepted to European Radiology. Then we were thinking, okay, there is information that can be retrieved by deep learning. What does deep learning see, what we do not see? And we were already interested in multiparametric analysis. So we were thinking maybe IFM analysis is a good way forward. And indeed, we saw that probably the deep learning algorithm, before ever that we saw this coming, probably looked at the IFM-F parameter as it really correlated with the gadolinium contrast MRI scans, and this has been presented at ISMRM in February in London this year. So Suzanne asked me, Martin, also give an overview not only of what you have done, but also what has been done in literature the last few years. And I took a quick look, and there has been some improvements in gaining evidence. In 2022, Erber showed that you can equally effective treat multiple fibroids as a single fibroid and have the same short-term outcome. And in 2020, Chengxia Li showed that it's better to assess the whole tumor instead of a part of the tumor as a region of interest when you want to look at K-trans, which is another multiparametric parameter in assessing MRI images. Although I have to say, from our experience, because we are analyzing this parameter as well, it is very difficult to get consistent quantitative outcome from this parameter. So we'll see what happens, whether or not we will prove also that this could be a predictor for immediate ablation response. So now we've covered the topic, what we actually know, and maybe it's more important now, what do we not know? We do not know the prospective mid- and long-term clinical effectivity because there's a lack of adequately designed randomized clinical trials. We have no good evidence of health technology assessments. For the connoisseurs in the room, we do not really know what's the difference between non-perfused volume assessed by direct ablation and indirect ablation. Sometimes you sonicate a few cells and suddenly all of the myomas are ablated. And we think that we have occluded vessels, but we're not for sure because we do not have a lot of treat or resect studies in these kind of cases. And most importantly, expectation management cannot adequately be addressed, neither by the referring physician or the treatment physician, and patients don't really know what they can expect beforehand. And I would like to quote Clemens here, my dear colleague from the University Medical Center of Utrecht. We should not neglect therapies that are almost there. We have seen amazing stuff here, inspiring, and it's all very important. But there seems to be a lack of focus in getting those treatments out there that are the most mature, to the point that we get reimbursement all over the globe, and we get into international guidelines. And Roberta said just a few days ago, Martin, we need to get in the guidelines. And this is a guy from Finland that already gets reimbursed, but not to the total extent. You can only treat a certain amount of patients, and the government starts to complain as well. Okay, so of all these questions, which are not answered yet at the moment, we designed the My Choice study. The My Choice study is an acronym. It stands for the Myoma Treatment Comparison Study, High Intensity Image Guided Focused Ultrasound versus Standard Minimal Invasive Fibroid Care, and it's a cost effectiveness analysis. Its goal to show non-inferiority in long-term cost effectiveness versus HIFU versus myomectomy, hysterectomy, and embolization. And it's designed in a 2-to-1 ratio, and we assess quality of life and cost effectiveness. We do it by questionnaires, and we do it by follow-up MR scans. For anyone who's interested in the details, you can find it in JMR research protocols. So, burning questions. We've got 3 of them. The first is, what are the new MR hardware and software developments, and how do these changes affect treatment time, MRI occupancy, and the cost? And the second question is, what image advances are out there, and what is the influence of artificial intelligence in screening the patients, creating prediction models, and maybe the possibility of new treatment monitoring opportunities? And the last question, and maybe the most important here today, which we would like to discuss with you, and also amongst ourselves, why is performing RCTs critical for clinical adoption and reimbursement? So far for the introduction. It's my pleasure and honor to introduce you Kullervo Hininen. He is a true pioneer in HIFU. He started off in 2004. It's about 18 years ago. I was still a resident then, and he showed already clinical results for MHIFU of fibroids, and he's now Sunnybrook's new Vice President of Research and Innovation. Dr. Kullervo Hininen, I think you're online.
Yes, I'm here. So could I get...
You're muted.
I'm not. Could I get the first slide?
Excellent.
Can you hear me?
Yes, we can hear you.
Okay, so I was asked to talk a little bit about the history of the devices. And the first device that was used for, and is still used, is the Chongqing HIFU device. And it has a spherically curved transducer with a single focus and uses very high amplitudes to generate thermal damage. It's guided by ultrasound, so there is no real online monitoring of the temperature. But it has been very effective and used in treating over 200,000 patients. Could I get the next slide, please? The next set of devices were developed inside tech, where you have a phased array built in the MRI table, and that phased array can move the focus up and down and then slightly around the focus, and that way control the focal position and shape, but still relies on mechanical motion of the transducer to different locations, but has MRI monitoring and control of the temperature. A similar device was developed by Philips, now marketed by Profound, where the focus is again made larger or smaller depending on the situation, and it's also MRI monitor controlled. And there is a third MR-guided device by Chongqing Haifu company, again relying on single transducer, but using MRI monitoring. Could I get the next slide? So those devices were limited, the MR-guided devices were limited phased arrays that allowed some control of the focus electronics. We have been working in the past too many years with trying to develop completely electronically controlled phased arrays. And you can see on that little module there that 64 elements, transducer elements, and then below that there is ASIC driving circuitry that can drive those 60 elements, each of them having independent phase and amplitude control and frequency control. And this technology has solved a long time problem that we cannot have completely electronically steered phased array. So these are like Lego blocks, and you can build any kind of say applicators with these elements. And we have built this blue squares there, where we have 90 of these blocks together, over 6,144 transducer elements, all independently controlled by electronics. So this, of course, provides now a system that doesn't have any moving parts. Everything is electronically controlled, provides really fast beam steering. And if you look on the MR image there of a fibroid, there you see the treatment planning, where we planning is showing where the acoustic focus is. Since you can control each of the elements and blocks, can turn them on or off, the field shape is changed and can be completely controlled. So you can generate multiple focal spots, and you can steer the beam with electronic beam steering really fast. And you also can cause nulling of the field. So you can eliminate the acoustic pressure and locations while still having focusing. And on the bottom there, you can see a table. This device has been used in a clinical phase 1 trial, demonstrating that we can actually get enough power out to ablate fibroids, and that the system is clinically usable. The system is now commercialized by various technologies. One good thing about this technology, it's a platform technology. Like I said, you can build any shape device, and you can use it for a bubble kind of treatments, or you can go all the way to histotripsy kind of pressure amplitudes. And that's the summary. So this should allow a reduction of the treatment times, but also might require use AI for optimizing the treatment, because the system gets very complicated and difficult for operators to optimally use. Thank you.
Thank you very much, Guillermo. It's a pleasure for me to introduce to you Johan van der Brink. He's also from the Netherlands. He's acquired a long track record at Philips, 27 years experience as a scientist, clinical solution architect, and is also an MS safety expert. I've heard he's traveling all around the United States for the last 2 weeks, but he just came in running, especially for you guys. Johan, take the floor.
Yeah, thank you for the kind invitation and opportunity to connect with this society here. And indeed, I have a long-standing history with Philips in R&D and the architecture department. I have 2 slides prepared. I think I'll have a few further comments to make beyond that. So where the MR technology plays, as you will all know, of course, is primarily in diagnosis. That's the core of our activities, and that's where the system is positioned. But there is a major opportunity to use MR maybe in the prevention space, but definitely in the treatment space. I don't have to inform you. And for that, we've seen about whatever 20 years, at least 15 years of advances in imaging technologies, and also recently AI-enhanced reconstruction methods. I want to mention those specifically here, I think, because they indeed allow for significantly faster scanning, but you need to be careful that image structures aren't just fading away due to deep learning reconstruction approaches. There are several reports already that, let's say, classification methods that were trained on MR image data from around 2012 just fall apart if you feed them with images generated with modern reconstruction methods. We believe that our AI-enhanced reconstructions are not subject to those sensitivities. So that's one part to mention concerning your burning questions already. And we also have a policy to upgrade all of our systems at any time with modern software. So the interfaces towards the treatment modalities that you see at the bottom of the slide, there's multiple of them. We aim to have one common architecture, one common interface, and we will upgrade basically all systems installed since 2010 or so to follow those interface advances. We believe that that's very important, so two things are important. First of all, make sure that software upgrades arrive at all of your install base, and secondly, make sure that your interface is versatile so that the multiple treatment modalities can benefit from that interface. Next slide, please. Now, to make that all happen, we are still not there yet. I've been writing multiple subsidy grants with people in Europe, at least, to focus on several of these aspects. So it's MR-only planning, which is critical not only in HIFU, but also in other areas like radiation therapy, of course. And those Dixon-based methods are there, but we need to show how AI can further make them more robust, but also faster. Then thermometry, of course, can benefit from AI, we believe. Biomarkers, I just showed two at the right-hand side. Just for example, diffusion was already shown. We have a unique biomarker which is FDA cleared and CE marked, called amide proton transfer rated imaging. We believe that we should look into that also in the context of this conversation. Then, of course, the beam steering requires accurate control and some innovations as well. And finally, to the lower right, you can't read it, but our mission is to have a real-time connected architecture that indeed is available as upgrade to all of our customers throughout their lifetime of the systems.
Right, thank you, Johan. We go over to our dear colleague, Bilgin Kerserci. He's an expert in magnetic resonance imaging physics and image-guided therapy, artificial intelligence, and finally also HIFU. Bilgin, the floor is yours.
Hello. Hi. Thank you very much for the introduction.
Bilgin, we cannot hear you, Bilgin.
You hear me?
Yeah, try it again.
Yes. Now okay? Can you hear me?
You have a big crack on the line here. It's difficult to understand what you're saying.
Okay, just 1 second, please. Can you hear me now?
Do you have another microphone?
No, I don't have it actually. Just 1 second.
Why don't the IT people work behind the scenes to try to correct his mic? And I'll go on to my slide for now, and then Bilgin will come back to you. Is that okay? They're going to try to help you fix your mic problem, and we'll come back to you in a minute, okay? You want?
Yeah, okay.
Okay, IT people, yep. Okay.
Suzanne, I don't need to introduce you, please.
Well, I'm not an expert in anything, but I have experience. So I'd like to share with you just some down and dirty things that I've learned over the years. I was fortunate enough to perform the first focused ultrasound procedure for fibroids in 2004 after FDA approval. And some of you may be questioning why I put an article from 2010 there, because it was my experience. I think that paper was published on patients I had done until about 2007 to 2008. And, you know, it was remarkable to put a patient on the table, treat them, and have them get up as if you've done nothing to them. And I thought, for sure, there's 10 million women in the United States that have symptomatic fibroids, and only 500,000 get a hysterectomy. Everyone's going to want this procedure. We're going to be able to really help these women that don't want invasive procedures. I was so excited. And then little by little, I realized that the biggest barrier was that there was no insurance reimbursement. I wasn't going to be able to pay for the machines. I wasn't going to be able to get other doctors to try to perform the procedure if there was no insurance reimbursement. That's the down and dirty of it. So after all of these years, I know that there is still potential to treat millions of patients around the world. And so I'm excited about today's discussion because to me there's three things I care about. Number one, patient selection. I want to pick the best patients that will benefit from this procedure. So you're going to hear today about ways that we can really improve patient selection. Number two, I want to do these procedures safely, fast, and efficient, and get them in and out. I mean, these patients would come into my outpatient practice, I'd put them on the MRI table, I would make them stay for an hour after to watch them. After 15 minutes, they wanted to leave. They're like, why do I have to stay the whole hour? So it was really like what Johan was saying. They would come in for a diagnostic MRI for one test, and then the next patient that came on would get a therapeutic MRI with focused ultrasound. The next one would be a diagnostic. The next one would be a therapeutic. So I want to get them in safely, fast, and do a good procedure. And number three, I need to get paid. So I really feel like these are the three burning questions here today. How can we pick patients who will really optimize and improve from the treatments? How can we do these treatments better? And number three, how do we get paid? So I'm very excited to hear from all of these experts on how we can get this done and get this into patients.
All right, Suzanne. Bilgin, are you ready? Is it working? Tech guys, is it up and running?
No?
Okay, then I would like to ask a question to start the discussion a little bit. Kullervo, are you there? Kullervo?
No Kalervo?
No? Okay, then I'll start with Johan.
Okay.
Johan, you've shown your vision on that the interface should be the same. That makes it easier for the treatment physicians to do a variety of patients. But how can you, maybe you could elaborate a little bit of how an MRI platform, as you have suggested, could have a positive impact on lowering the cost per patient to treat?
I think there is multiple answers to that. As I'm coming from a system architecture perspective, and let me start from there. We need to leverage economy of scale. So the systems that are used for treatment and intervention should be built based on the same platform as is being used in diagnostics. That means, where possible, same magnet, same software, same user interface, and a easy or, yeah, so that's where the problem comes, mechanical interface. But that's a very important thing to make sure that it can be an economically viable solution. And that's one part to it. Then the other is I'm struggling a little bit here, but I think we need to leverage the capabilities of the pulse programming and reconstruction interfaces and find ways to either use good quality reconstructions that we own as MR manufacturer, or enable the treatment modality providers to really innovate on their needs. So there should be an open interface, and that's why this interface is so extremely important to us.
So you think by facilitating the manufacturers in a way, you could take away some of their burden and one platform, and that would reduce the cost. Is that a way forward?
Yeah, but also make sure that these treatments modalities can innovate their software to their needs. So both from our end as an economically viable solution, as well as in the clinic, we need to make sure that the cost of the system is managed in a well-controlled manner, so to say.
So
that doesn't solve, by the way, your problem of economic viability in the clinic, of course.
No.
But first of all, let's make sure that you get a system that works.
Let's do a cooperation. Okay, try again. Kullervo, are you there? We see your shoulder, Kullervo. There he is.
Okay, how about now, finally, is okay?
Oh yeah, is that Bilgin, is that you?
Okay, please go ahead and next when I can talk.
Okay, Kullervo, we come back to you later. Bilgin, please, fire away.
Okay, no problem.
I think this is your first slide, right? Yeah.
Okay, yes. I apologize for some technical issues. I'm not sure why it happened. I just had to change the camera. First of all, I'm a medical physicist. That's actually the head of medical physics department at University of Sains, Malaysia, at this moment, and also the director of the Intelligent Healthcare and Innovation Research Center at Yildiz Technical University in Istanbul. After spending almost 20 years in industry as a medical physicist and MR physicist and also a HIFU scientist, now currently I'm spending more time on the research for HIFU treatment of uterine fibroids and adenomyosis. And as you can see there in the first slides, that actually so far we have been working on the center slice, the largest fibroid, when we are doing analysis of all the classification or the prediction of the treatment. So now, based on some limitations coming from the tissue characteristic, that we have decided to work on the volume. So try to understand more about the uterine fibroids and adenomyosis to be able to classify and choose the right patient and also improve the efficiency of the treatment. Next slide, please. So basically now we have been working on, in addition to the vernacular classification based on T2 imaging, we try to look for the multi-parametric perspective, so based on the histopathological outcome, just like we try to look for what kind of information we can get from uterine fibroids and adenomyosis to be able to choose the right patient. That's mainly based on the cellularity and vascularity, perfusion and diffusion. So to do that, we have a limited data, but for this, we try to understand how is all correlated to each other. So to understand more about this for improving the treatment outcome, so we try to use the different machine learning algorithms and also deep learning, try to learn how it works comparing to the standard analysis. The next slide, please. So basically, if we can look at here, this is just accepted, but it's still in the press. When we're simply looking at the ROC curve or the feature importance, we can easily see what parameters is very important, but it is not easy to say that how it correlated, and also when we're talking about for the confusion matrix, just analyzing true positive and false positives, the values that each multi-parametric MRI, that what kind of information they're giving us. So when we can easily, when we look at the literature, we can say that, okay, so K-trans is one of the most important, or the fat thickness, or T2 signal intensity, so on. But the problem is that after that, all the parameters, how it correlated with the outcome of the treatment, that we still don't understand exactly the correlation behind. For that purpose, not just simply by looking at the correlation, but also we try to understand each parameter, how it can contribute to the MR tissue characteristic, not just the T2, but also perfusion and also multi-various diffusion. So basically now, based on for the international collaboration, that with some institution in Asia and also Turkey, we try to develop an algorithm and to classify the fibroids and uterine adenomyosis to improve the selection of the patients for HIFU. And also not just only selecting the patient, but also when we analyze all these complex parameters, how can we contribute to the treatment? It's kind of a prior knowledge given to the system, like Dr. Heenan mentioned about that. It's a complex system is happening, so how can we use artificial intelligence to make it less complicated? That's for now, and I will explain for the next in the question part, hopefully more. Thank you.
Thank you very much, and thank you for the technicians to solve this problem. I would like to back to Kullervo. Kullervo, you showed us a new feature of new arrays to treat patients. What's your expectation? Does it positively influence the reduction in treatment time if you approach this differently?
Yeah, based on the physics, my expectation is that we should be able to reduce the treatment time to half, at least, and make more patients treatable with the device. But it requires the system to use normally, and for that, it can be complicated.
Okay, that's great news. Thank you very much. Is there anyone of the panel who would like to ask each other a question, or should I just go on?
Yeah, Kullervo, with this new machine, I know sometimes I had trouble accessing certain parts of the fibroid because I'd have to mitigate like a bowel loop that was in a funny angle and things like that. So how narrow a beam could you still use and get effective ablation from, let's say, 6 centimeters from the skin surface?
Well, it's still limited to similar issues than you have with the attenuation issues. So you have to be able to focus. So if you have lots of power in front, you cannot do it well. But I think with the manipulation techniques, we can help that. And the other issue is that if you can run it at the high pressure amplitude level and generate gas pockets, then you can reduce the time of its power and the angle, the window that you come in. Yeah. But those are techniques that require lots of experience and knowledge.
Mm-hmm. Well, I'm sure for those of the people in the room who perform these procedures and the people who want to, I mean, this adaptation could really improve treatment times and accessibility to obtain a higher non-perfused volume in the fibroids. So I look forward to hearing more about the results from your clinical study and more work to do on the technological improvements to improve the technical efficacy and safety of the machine.
Okay, thank you. Bilgin, I have a question for you. We have investigated that you have to have a minimum of 63% non-perfused volume, and your machine learning algorithm is about 90%. How good are you at estimating the 63%? Oh, you're muted. You're muted. You have to press the button.
Okay. Basically, what we are looking at is that we try to see is actually not only 90%. We are looking at more like more than 60%, 70%, 80%, and also 90%. The main reason that we choose, okay, the data we have done for this We are trying to persuade the gynecologists, not only radiologists, to be able to them to adopt this system to, because when we look at actually the clinical outcome, the improvement of the symptoms is actually 60% plus that we can see the improvements. But in order to understand whether to have the people adopt the HIFU system, we try to look for about the higher volume without sacrificing any safety issues. So at this moment, by looking the artificial intelligence deep learning methodologies, that's just one criteria, but the major problem of this is the data. We don't have enough data actually. We have very limited data, so it will be very difficult to say how accurate it is, but at this moment, we try to understand what kind of multiparametric features can tell us to reach that level, to explain especially my part that I'm more like working on the perfusion, all the looking at the vascularity. That's trying to see whether we can truly catch that 90% or not. However, that's simply just for based on the data we have. But we must be able to try the lower value as well.
All right, thank you. Johan, you have a question?
Yeah, I have a question and a comment, I think. Where machine learning is very promising in, let's say, feature selection and prediction of outcomes, there is also a reason for a little warning there, especially when you're discussing the availability of data. As I mentioned already, with the advent of nonlinear reconstruction approaches, to make this effective, we will have to make sure that the data that we feed into these models is curated well, but also that the results generalize. I've seen examples as of recently where any of those multiparametric prediction models trained on data from 2015 or 2012 for that matter, miserably fail with modern reconstruction algorithms. So the warning here is to this society as well, don't be discouraged if it breaks down, just make sure that your quality control is in place.
Yeah, and maybe that's also a good idea that we, a data bank that we could actually pool patients and that you can live yourself out, Bilgin, on all those data that will become available. I also would like to say something about, I would like to be the advocate's devil. If you talk about machine learning in ablation, one of the key issues is how far do you want to go? How long do you want to ablate? And it's my opinion, but I'm wondering whether or not you agree with me or the other panelists agree with me, that the best outcome measure for prediction for ablation is how quickly, at a certain given amount of input energy, you come to the terminal lethal dose. So I think that's the most important outcome measure, actually. What do you think about that, Bilgin?
Okay. Yes. Basically, yes, I agree with you that the outcome is very important. But before we reach to that point, we have to understand what kind of fiber tissue we have. So instead of doing everything during the treatment that they already have a limited time and we are complaining that it's quite long. So by looking at the complex data, try to understand not just the selecting the patients, but also we have to look at the volume data, not just the center slice or where the fibroid is the largest to make a simple classification to go to the treatment. Then we have a big problem. Even if we have a faster system or we have a high powers to deal with vascularity or cellularity, whatever we have, the problem there, but we have to know where to start first. So for this purpose, the machine learning that will give us probably the classification based on the volume. not just simply for the slice we are looking at. Then I think after that, if we have this prior knowledge, then the transducer that Dr. Heenan mentioned, that will be very efficient because we will know
Thanks.
the map of the fibroid. So, yeah.
Excellent.
Yeah, those are all really important points to consider. And something else that I used to come across in practice is when you used to sonicate an area and get an ablation, and then all of a sudden you think you're amazing because you get an ablation much larger than the area you sonicated. And it would show up as a non-perfused volume in the post-contrast images or your diffusion images. But those are the areas that tended to recur. So what you think is ablated tissue may just be stunned or a small UAE effect. So we need to also take into account in all of these modeling and things, areas that you're directly ablating versus those areas that are indirectly getting ablated.
Clervin, can you ask you a question? The new devices, how will that positively influence the amount of energy that you can quickly deposit in tissue?
So, I mean, we have, in the device, you have over 6,000 transducers, so you can really go to very high pressure amplitudes if you want to. So, these modules we have tested, like with 16 modules, you can go to 30 megapascals, which is enough to create gas bubbles and disintegrate the tissue. So if you want, you can do that kind of therapy. So you have full control over the energy deposition and the distribution. I think what is the most useful of this device is that you can create a field that has zero pressure amplitudes on critical structures, which helps you then avoid pain and so forth.
Okay, thank you. Suzanne, question for you. You have a lot of experience. You've seen the evolution of the treatment, but we're not there yet. So, what do you think we should do as a society, as a group? What should we do to actually nail this application? What do we need to do?
Yeah, I don't think it's any one thing. I think number one, your RCT is going to be really important data for everyone to look at. So thank you for persevering and getting that study off the ground. And I think what Kalervo and Kasursi and Johan are doing are also, we need technological improvements, software improvements, patient selection. We need to show people that we have an algorithm that works, that can really improve the care of patients that will benefit from it. So, you know, at first, although it was this great new technology, we need to back up a few steps and do things the correct way to get to the end run. So maybe a step or two back, but it will help us move 4 steps forward. So, you know, I hope everyone in this room takes it upon themselves to maybe research one of these areas that we've identified today and make it better. So it's not just one thing.
Excellent. Well, as you can imagine, we can talk over this for another 4 hours. We won't bother you with that. There are other speakers, other moderation sessions. We've got 2 seconds left. I would like to thank Kalervo, Bilgin, Johan, and of course you, Suzanne, for this amazing panel. It's been really diverse. Clinicians, hardware, software, machine learning. We can only be grateful that we have such a group of people together working on this topic. Thank you very much.